honor for me to introduce Lakshmi ma'am. I am really feeling privileged to introduce Lakshmi ma'am for the talk. Madam is Medical Director Shrikhande Fertility Clinic Nagpur, Maharashtra. Madam is past President Nagpur OBGY Society and past President Menopause Society Nagpur. Madam is immediate past Chairperson ICOG and she is National Corresponding Editor of Jogi. She is National Corresponding Secretary of Association of Medical Women of India, and she was President ISOPAB with Vidrawala chapter from 2019 to 21, and she was also the chairperson IMS Education, and she was the Vice President Foxy in 2012, and she is currently chairperson Fertility Enhancement Committee ISOPA, and she is the member of Suffolk Education. And Madam has several national and international publications. She had 42 national and 21 international publications. And Ma'am has received several awards. She received appreciation letter from Maharashtra government for her work in the field of Save the Girl Child. Madam has received several awards from like Nagpur Ratan Award, Bharat Excellence Award, Mehru Dara Hansotia Best Committee Award. Ma'am, it's a great pleasure for us to hear you.
Thank you. Thank you so much, dear, for your kind words. Yeah. So may I share my screen? Yes. So I'm so happy to be the last speaker here because the theme of our webinar today is PCOS across the life cycle. So you have heard how to manage a case of adolescent PCOS from Dr. Supriya. You have also heard the fertility challenges from Dr. Yusuf Latif. And now it is the metabolic syndrome in PCOS, which is the prevalence of this metabolic syndrome is as high as 33% in women who are suffering from PCOS and is associated with long-term consequences such as cardiovascular disease, type 2 diabetes, cancers, sleep apnea, and psychological problems. And I'm so happy that both my previous speakers, they touched upon this aspect of PCOS in their presentation. Because conventionally, management of PCOS, whenever we talk, it is usually focused on infertility, anovulation, hirsutism. But now there is need to increase the clinicians' awareness about the metabolic syndrome in cases of PCOS. Because the enormity of the health burden of this metabolic syndrome means that accurate identification and timely intervention are extremely important. So what is the late sequelae? We are all worried about PCOS. She is 7 times more prone to get type 2 diabetes, 4 times more prone to have hypertension. She is more prone to have dyslipidemia. She is more prone to have endometrial cancer. Pathophysiology, everyone knows, so I am not going into the details, but we all know that the insulin resistance and its consequent hyperinsulinemia is central to the pathogenesis of PCOS. Insulin regulates the metabolic and mitogenic pathways that function independent of each other. And that is why this might explain the paradoxical insulin sensitivity patterns which are seen in different tissues. For example, we see resistance in peripheral tissues and retained sensitivity in the ovarian cortex. Metabolic inertia to insulin has been attributed to a post-binding defect in the insulin signaling pathway, which is caused by abnormal serine phosphorylation of the insulin receptor. And despite extensive data supporting the role of insulin resistance, it still remains unclear whether the association between PCOS and insulin resistance is causal, propagative, or merely coexistent. So now let us see its effect on atherogenic dyslipidemia. In adipocytes, insulin resistance leads to the increased shunting of free fatty acids from fat tissue to the liver. These free fatty acids, they induce hepatic synthesis of very low density lipoprotein, resulting in elevated triglycerides and apolyprotein B and decreased HDL. These alterations in lipid parameters, they lead to atherogenic dyslipidemia. PCOS is associated with chronic low-grade systematic inflammation, which mediates insulin resistance and it accelerates the atherogenesis. Besides genetic abnormalities, obesity and a high glycemic diet are also known to induce pro-inflammatory cytokines such as tumor necrosis factor alpha and interleukin 6. Now coming to the obesity. Obesity, it is known to perpetuate PCOS. It most likely results from the combined effect of genetic predisposition, poor diet, and a sedentary lifestyle, thus compounding the pre-existing metabolic derangements. Hyperinsulinemia and the increased responsiveness of the ovarian theca to insulin causes an increase in the levels of free androgens, and hyperandrogenemia increases a person's predilection for central adiposity and it worsens the insulin resistance and dyslipidemia. Now, what about hypertension? In obese individuals, hypertension is linked to the potential of sympathetic outflow and the renin, angiotensin, aldosterone system, resulting from increased levels of insulin and free fatty acids. Concomitant vascular endothelial dysfunction also contributes to the development of hypertension, and analyzing all available data on the etiopathogenesis of PCOS, it is evident that a paradigm shift has taken place in our understanding of metabolic syndrome in PCOS from mere ovarian dysfunction to a multisystemic, multifactorial aberration with far greater metabolic consequences that initially were implicated. Now, the effect of insulin resistance on cardiovascular disease. The one meta-analysis demonstrated that in women with PCOS, the risk of coronary heart disease and stroke is doubled. Despite adjusting for body mass index, there was a 55% increase in risk. Subjects with metabolic syndrome are 3 to 6 times more likely to develop CHD with a 12% increase in mortality. Where metabolic syndrome coexists with PCOS, one would expect this risk to be significantly higher. Large-scale prospective studies that evaluate long-term outcomes are required to assess the magnitude of the impact of metabolic syndrome with PCOS on cardiovascular disease. Coming to diabetes, metabolic syndrome confers a 5-fold increase in the risk of type 2 diabetes, and PCOS has been identified as a significant non-modifiable risk factor. Women with PCOS with baseline normoglycemia, they have a more pronounced risk of developing impaired glucose tolerance, and up to 16% of women with PCOS, they convert to IGT per year. Women with baseline IGT have a 2% risk of progressing to type 2 diabetes mellitus per year, and over 6 years, this risk may be as high as 54%. A meta-analysis on the impact of PCOS on reproductive outcomes has shown a 3-fold increased risk of gestational diabetes. Now coming to the cancer, we all know that PCOS is associated with an increased likelihood of endometrial cancer. However, it is difficult to ascertain the independent effect of PCOS because of the additive influence of diabetes, hypertension, obesity, chronic anovulation, and hyperestrogenemia on the development of endometrial cancer. There is no strong association between PCOS and ovarian or breast cancer. Metabolic syndrome has been associated with an increased risk of endometrial cancer, that is odds ratio 1.6, and a higher incidence of pancreatic, postmenopausal breast, and colorectal cancer. In this study, the odds ratio was 1.5. Poorer cancer outcomes, increased recurrences, and overall mortality have also been linked to the metabolic syndrome. Now coming to the obstructive sleep apnea, which Dr. Yusuf Latif was talking, PCOS is associated with up to 30-fold higher risk of obstructive sleep apnea and a 9-fold increase in excessive daytime sleepiness. Insulin resistance has emerged as a principal predictor for the risk of obstructive sleep apnea, independent of the elevated testosterone levels and obesity. The presence of OSA in metabolic syndrome in turns worsens insulin resistance and cardiovascular outcomes. So women should be screened for and they should be counseled about snoring, daytime sleeping and fatigue, and they should be offered interventions when necessary. What about the psychological problems? The prevalence of depression is higher in women with PCOS than the general population, with increased severity of symptoms. And this association is independent of body mass index. These women are also more likely to develop anxiety, eating disorders, and dysfunctional relationships. Metabolic syndrome is associated with depression, mainly with neurovegetative features such as fatigue. Although inflammation has been linked to the development of depressive symptoms, the precise mechanism have yet to be elucidated. Since these factors significantly affect quality of life, it is essential to screen women for symptoms and to refer them to specialists when required. So now how to diagnose the metabolic syndrome in PCOS? Remember, metabolic syndrome, it was first identified as a clinical entity with insulin resistance central to its pathogenesis. Thus, historically, the definition of a metabolic syndrome mandated the presence of insulin resistance for its diagnosis. Subsequent definitions, they included more composite criteria. For example, they included waist circumference as a measurement of central obesity. Multiple definitions for metabolic syndrome have been proposed over the years, reflecting a shift in the proposed pathogenic mechanisms and clinical implications. These are the various organizations which have proposed various definitions of metabolic syndrome. They are WHO, the International Disease Federation, the National Cholesterol Education Program, American Heart Institution Association, National Heart, Lung and Blood Institute, and Adult Treatment Panel 3. What are the diagnostic criteria which all associations have used? They are the high waist circumference, high blood pressure, high triglycerides, high glucose levels, that is fasting glucose, and low HDL. These are various organizations I have already described. They have come out. So NCP thing, any 3 of the 5 criteria. Most of the associations are saying any 3 of the 5 criteria except IDF, which is saying elevated waist circumference with any 2 of 4 criteria. So I will not confuse with you with this slide. It's a very crowded slide, but going through the definitions of all the associations, the definition of joint interim statement, that is all these associations, they collaborated with each other to come out with a joint interim statement about the definition of metabolic syndrome. And now this simplifies its utility as a clinical tool and has emerged as one of the most commonly used definition. So JIS is saying any 3 of the 5 criteria. Now, screening of metabolic syndrome is very, very important because we all are seeing adolescent PCOS. We are seeing them in the reproductive age group. So, a structured assessment for the early detection and management of metabolic syndrome, especially in women of reproductive age, would be of critical importance to the healthcare system so that it can be applied in the clinical setting. This assessment would need to prioritize risk, standardize the evaluation methods, and establish the frequency of further testing. A comprehensive evaluation of the risk factors for metabolic syndrome adapted from evidence-based guidelines from Australia and UK's RCOG I am showing you in this table. India, we don't have any guidelines, but this is how RCOG has said that you have to screen these women in the reproductive age group, ask the history of cigarette smoking, look for BMI, their waist circumference, blood pressure at every visit. Then you have to do lipid profile and oral glucose tolerance test. And they have given that if she is having BMI less than 25, you should do lipid profile and OGTT annually. If she is having BMI more than 25, then you have to do lipid profile and OGTT at every visit for women with a normal profile, and then every 2 years. For women with an abnormal profile or having high BMI, you have to do annually. So these are the guidelines given by RCOG. We can adapt it to our circumstances. Now, how to manage? With metabolic syndrome adding to this epidemic of type 2 diabetes, CVD, we have to institute early interventions, and targeted interventions is need of the hour. So the primary intervention for metabolic syndrome requires adopting lifestyle changes, which has been covered in great detail, that may prevent or slow progression to adverse events in high-risk individuals. In those who do not respond adequately to lifestyle modifications, secondary interventions can be considered, including drug therapy and bariatric surgery. So the lifestyle modifications again has been covered in great detail by Dr. Yusuf Latif. So they have to focus on diet. It is advisable to refer them to a nutritionist, and they need an exercise schedule as well. Now coming to the medical management for metabolic syndrome. Now remember, we all know that metformin improves the insulin sensitivity, and it has also been shown to decrease the fasting insulin levels, but this benefit was restricted to non-obese women with PCOS whose BMI was less than 30. There is no robust evidence for the use of metformin to merely ameliorate the insulin resistance associated with PCOS, and its use to combat the same in normoglycemic women is not recommended. Women with IGT who have a significant risk of conversion to type 2 diabetes, metformin can be considered for use in these women. Metformin has been used in incremental doses ranging from 500 to 1500 milligram per day. There is no consensus as far as the duration of treatment is concerned. Does inositol has any role in the metabolic syndrome management? Various studies have demonstrated that administration of DCI leads to decreased basal insulin levels and improved lipid profile, and it reduces the systolic blood pressure. So the preliminary data suggests that supplementation with inositol can be considered for improving a patient's metabolic profile, but more studies are required before its use can be standardized. Now, what about the anti-obesity agents? We all have Orlistat. It induces significant and sustainable weight loss with similar efficacy to metformin. Based on available evidence, Orlistat can be considered for the treatment of overweight and obese women with PCOS for whom lifestyle modifications are insufficient. The dose is 60 to 360 milligram per day divided between 2 to 3 doses. Extending this favorable effect to cardiovascular risk, Orlistat might have a role in the management of metabolic syndrome as well. However, further studies are required to assess the use of Orlistat in those women with PCOS and metabolic syndrome before it can be approved for therapeutic indication. Another anti-obesity agent is liraglutide, and the use of liraglutide is limited by the need of parenteral administration and the frequent occurrence of the GI side effects. Now we were talking about semaglutide. Remember, the FDA approved the semaglutide containing medication for chronic weight management in adults with obesity or overweight with at least one weight-related condition. So just for weight loss, it has not been approved by FDA. Obesity has to be associated with at least one adverse effect, which is because of the obesity. Then yes, you can prescribe semaglutide and it is available in India also. What about the prescribing statins for metabolic syndrome? They seem to create a favorable metabolic environment. Their use is limited by certain risks, but yes, you cannot routinely recommend statins in cases of metabolic syndrome with PCOS, but apparent benefits of medical therapy must be weighed against the risk of potential adverse effects if you have to prescribe statins. Surgical management, again, Professor Yusuf Latif has told you about the bariatric surgery, that when other management strategies are failed, bariatric surgery may be offered to those who have class 3 obesity, that is where BMI is more than 40. Bariatric surgery may also be considered in women with class 2 obesity, that is where BMI is between 35 to 40, where with this BMI, she is having chronic medical conditions such as diabetes and hypertension. So these are the two indications for bariatric surgery. But all said and done about the metabolic syndrome, you all will agree with me that prevention is better than cure. In order to prevent metabolic syndrome, we need a multi-pronged approach, which should include behavior modification, dietary modification, increase in physical activity, and prevention of smoking and excess use of alcohol. So where to catch? We have to catch them young. Schools are the best. They offer an ideal medium for lifestyle interventions because the obesogenic lifestyle behaviors are less well developed in children and therefore they are amenable to change. So we have to target the prepubertal and adolescent girls as they are the future mothers. We have to catch them young. 42% of the girls between 6 to 10, they really wish that they should be thinner. So lifestyle modification is very simple. If we reach out to these young girls and we can teach them about the balanced diet and physical exercise. And what is the role of obstetrician? Because in our OPD, day in and day out, we are seeing cases of adolescent PCOS. We have the opportunity to counsel their mothers as well, because usually they are accompanied by their mother and father. Of course, we can reach out to the schools. But as an obstetrician, we are also dealing with the cases of pregnancy, and you have to here take this opportunity to counsel her about the long-term sequelae and about the metabolic syndrome, because it is our responsibility not just to treat that adolescent PCOS for irregular menses or hirsutism or infertility just for pregnancy or pregnancy with PCOS just till she delivers. It is our responsibility as a treating clinician that once she is correctly diagnosed, as Dr. Cipriya said, not underdiagnosed, not overdiagnosed. If she is correctly diagnosed with PCOS, you have to take 2 or 3 minutes extra to counsel her about the possible long-term health risks which are associated with PCOS, and you have to tell her about the screening methods, how frequently she has to do, and what test she has to do. So the key takeaways from my presentations are that the risk factors for metabolic syndrome, they include central obesity, hypertension, atherogenic dyslipidemia, and insulin resistance. It affects 33% of women with PCOS, and it has been less well researched than other features such as infertility, anovulation, and hirsutism. Consequences of metabolic syndrome include cardiovascular disease, type 2 diabetes, cancer, sleep apnea, and psychological problems. Cardiometabolic risk screening involves obtaining data on her smoking history, measuring her weight, calculating her body mass index, waist circumference, blood pressure, lipid profile, and doing an OGTT. Management of metabolic syndrome should focus on the risk factors and individual components. Lifestyle modification is the only universally accepted intervention. Metformin can be considered in those women who have impaired glucose tolerance although there is no established duration of treatment, the use of newer drugs such as inositol, liraglutide requires further validation, while the use of statins should be limited only to those women who are having dyslipidemia. Bariatric surgery can be considered as a last resort in appropriately selected women. And last but not least, prevention is better than cure. So catch them young in schools and in your OPD when they are coming to you for management of adolescent PCOS, infertility, and PCOS with pregnancy. So thank you, friends. Thank you.